In this last portion of the lecture, we're going to talk about how bones get their strength, the things that are required for good bone health. We're going to talk about fractures and how they heal. And we'll finish up with just a few words about osteoporosis. But let's begin with the strength of bone. The important thing to remember about bone is that its strength is due to a combination of the mineral material that we talked about in the matrix and the protein material, the collagen fibers that run through that matrix. Remember, I used the analogy of reinforced concrete. In order to have the strongest foundation, you need both the concrete and the rebar. You need both the mineralized matrix and you need the collagen fibers running through it to give bone its greatest strength. Now, you probably know that part of the way to maintain bone strength is to use your bones to exercise. Exercise is critical, of course, for the overall health of the human body, and that includes the health of the bones. So when we exercise, and in particular when we apply mechanical stress to the bone, it helps the bone maintain its strength. In fact, it is critical for the bone to maintain its strength. You must use your body or your body will not stay healthy. And the same is true of the bone. What's interesting is that the more we weight bear, the more that we put concussive force, so the more that your bones experience the impact of your body and the ground below it, the stronger your bones will be because the more dense the bone will become. So it's not enough to exercise in a way where there is no stress on your bones. You have to walk around at minimum. We see this in people who stop putting any mechanical stress on their bones. We see a loss of bone density. Probably the greatest example of this is the astronauts that go to space for long periods of time and are simply no longer under the influence of gravity, and so are no longer applying force to their bones by connecting with the ground beneath them. There's no concussive force of walking or running or doing any kind of movement like that. And what happens to those astronauts over time is their bone density decreases. When the bone doesn't get the signals of mechanical stress, of concussion, of the legs against the ground, when the bone doesn't get that information, it starts to get out of balance. And the way it goes is more towards the osteoclasts removing bone and less towards the osteoblasts creating bone. So it gets out of balance. Another way that you can see that is in people who have a bone casted because they've had a fracture. In the old days, we used to use casts much more frequently, and we would use them for longer periods of time. And what we discovered was it was not good for the bone. Yes, the fracture would heal, but the density of the bone would suffer because with the leg or the arm in the cast and not being used and not experiencing any kind of mechanical force, the bone density would start to decline. So we're now a lot more conservative about leaving casts on. We get casts off as soon as we can and replace the cast with something that allows at least a little bit of mechanical stress to be applied to the bone. So when it comes to exercise, Resistance training is actually more effective than aerobic exercise, cardiovascular exercise for the health of your bones. So weight training, in other words, resistance training. You are, when you do that, you are applying mechanical stress. And it's that stress that the bone needs. It needs the pull of contracting muscle upon it in order for the signal to be interpreted by the bone as a need for increased bone density. It's especially important in elderly people that resistance training is part of their daily exercise. Just plain old cardiovascular is very good for us, but it is not the best for bone health. The best thing for bone health is resistance training. And because elderly people are more susceptible to bone fracture, it's especially important that they have a little resistance training as part of their routine every day. So our bone really does strengthen to our activity level. People who are more active, people who are more athletic, people who are out and about and moving and busy and active have the greatest bone health. And the more and more sedate a person gets, the more restricted they are in their movement, the more they sit around, the less healthy their bone will be. So a sedentary lifestyle is not a good lifestyle for our bones. And they start to lose strength, they start to lose density. Of course, another thing that will impact our bones is malnutrition. It's not just about people in other countries being malnourished. There are a lot of people in our country who are also malnourished. And remember, you don't have to be thin and skinny to be malnourished. There are plenty of people walking around who are overweight and obese, and even morbidly obese, who are malnourished because they're not eating the correct balance of food. The most important things in terms of bone health are calcium, vitamin D. Those two things work together synergistically. Vitamin D also works in synergy with vitamin K. And the omega-3 fatty acids are important. Now, the omega-3 fatty acids are helpful because they help keep inflammation in check. So just overall systemic body-wide inflammation can be a problem, and a diet rich in omega-3 fatty acids will help keep that in check and help keep the bone healthy. So bone health is intimately tied in to exercise, and particular types of exercise, and to nutrition. But the other thing that's critical for our bone health is the balance of the hormones in our body that help keep our bones healthy. Remember, bone is a dynamic tissue. It is constantly being pushed and pulled towards the side that adds bone and the side that removes bone. And we have to keep those two sides in check with each other. We have to keep them in balance with each other. And hormones do a lot of that work for us. For example, growth hormone is the hormone that is responsible for ultimately achieving the greatest length of the bones. So growth hormone is critical for the continuing growth of bones throughout childhood and adolescence. Growth hormone also contributes to good bone density. Thyroxine, if you're not familiar with it, is thyroid hormone. Thyroid hormone also contributes to bone growth and to the health of the bone matrix. The sex hormones, you may not think about things like estrogen and progesterone and testosterone being involved with bone health, but they're critical for bone health. Those hormones, estrogen and progesterone in the female and testosterone in the male are able to stimulate bone formation. So they stimulate osteoblasts, particularly during the adolescent years, during the time when teenagers have their growth spurt. They also contribute to ultimately what will close the growth plates, these sex hormones. Calcitriol, a hormone called calcitonin, and the parathyroid hormone are also really important in bone health. Calcitriol and parathyroid hormone are necessary for good absorption of calcium from the gastrointestinal tract, and calcitonin helps the bone take up all of that calcium. Parathyroid hormone also helps stimulate osteoclasts and pushes that bone balance towards bone resorption. So as the sex hormones are stimulating the osteoblasts, the parathyroid hormone is stimulating the osteoclasts. Again, you got to keep the production of bone, the growth of bone, in check with the resorption of bone so that the bone stays balanced. And finally, calcitonin, like the sex hormones, helps stimulate osteoblasts, or more on the growth side for bone. So all of these hormones are important. Don't worry too much about what each individual hormone does, but understand that what they're all contributing to is maintaining this balance between bone production or growth and bone resorption or loss. And they do that by stimulating either the osteoblast side or the osteoclast side. And of course, they're also important, as I said, for the absorption of calcium and the uptake of calcium by the bones. All right, we're going to switch gears here, and we're going to say a few things about bone fracture and how the body repairs bone when it's fractured. Bones will fracture when they are placed under particularly strong or particularly unusual forms of mechanical stress. Remember, mechanical stress is good for a bone, but you don't want to apply too much stress or too much force, particularly in strange directions, onto bone, or the bone will fracture. Now, there are different types of fractures that occur based on the forces that were applied that caused the bone to fracture. A simple fracture, or what we sometimes call a closed fracture, this is when you have just a break in the bone and the broken ends of the bone stay inside. They don't penetrate out through the integument. There are fractures called compound or open fractures where those broken ends of bone actually do tear through the muscle tissue, the subcutaneous tissue, and through the integument. And so you'll see the broken ends of the bone actually sticking through the skin. As you can imagine, it's a better situation to have a simple fracture or a closed fracture, because once a compound fracture occurs and the skin breaks, you've now lost one of the barriers to infection. So one of the biggest problems with open fractures is the infection that can set in. Now, there's a type of fracture called a comminuted fracture, where the bone doesn't simply break, but it fragments at the fracture site. It splinters at the fracture site. There's a type of fracture called a stress fracture. This is a very thin break in the bone. Stress fractures are the kinds of fractures that come from usually too much of one kind of physical activity. If you've ever had a stress fracture, it's very common to get one when you're doing the type of activity that repeats and repeats and repeats. So, for example, you can get stress fractures from running, and you can get stress fractures from playing certain athletic games where you're making these repetitive motions. The last kind of fracture that I'm going to talk about is what we refer to as a pathological fracture. This is a fracture that comes about because there's some other kind of disease in the bone, and that other disease has weakened the bone. So, for example, a person who has osteoporosis can fracture a bone from something as simple as coughing. Osteoporosis creates such a loss of density in the bone that even some very normal mechanical stresses can break the bone. Cancer is another big player in pathological fractures. One of the ways that we find bone cancer is because somebody, typically, unfortunately, a young person, will come into the hospital who has fractured a bone simply outside playing, simply from, playing football or riding a bicycle or doing some kind of very normal athletic activity. The bone fractures because the cancer has unfortunately broken down so much of the normal bone that it simply can't take even normal mechanical stresses. I just want to go through a couple of the terms that we use to describe fractures, just so you're familiar with them. These are words that we would use to characterize a fracture. So other than talking about whether it's open or closed, and talking about whether it's comminuted or a pathological fracture, you'll also hear terms like displaced fractures, green stick fractures, spiral fractures, and all of these words describe what the fracture is going to look like essentially on the radiograph. So displaced versus non-displaced describes whether the ends of the bone at the fracture site are aligned or misaligned. Sometimes during the course of the fracturing process, the two ends of the bones pretty much stay in place, they just break apart from each other. That's a better situation than if the two ends of the fracture become misplaced or misaligned from each other, because the surgeon is going to have to align those two bones again to allow them to heal. Green stick fractures are really common in children. These are fractures that don't break through both sides of the bone. They're called green stick because if you've ever broken a stick with your hands, a wooden stick with your hands, that has some very young wood inside of it, you know that it's very hard to break that stick all the way through. That stick would be considered green or young, and a green stick fracture is very similar. The bone doesn't break all the way through. The transverse fracture occurs across the transverse plane. A linear fracture occurs parallel to the diaphysis of the bone. There are diagonal fractures called oblique fractures. And then there are spiral fractures that literally spiral down the bone in 3 dimensions, like walking down a spiral staircase. So there's all kinds of terminology that we use when we're describing fractures. On this slide, up on the left-hand side at the top, this is a diagram showing us the difference between a simple fracture and a compound fracture. So a closed fracture and an open fracture. And you can see they've drawn the soft tissue in gray to show that this fracture is still within the tissue, but this fracture has broken out through the integument. And then down at the bottom of the slide, these are just diagrams of some of the different kinds of fractures that I've mentioned so far. Comminuted, meaning just fragmented, bits and pieces and splinters of bone at the fracture site. Here's that green stick fracture, which has gone through one side of the bone and not the other. Here's a spiral fracture, sort of twisting around the length of the bone. This is an oblique fracture. This is a linear fracture. This is a transverse fracture. Lots of terminology to describe these breaks in the bone. One of the most interesting things about fractures is how they heal. In young people, children, we're talking about a period of maybe 2 to 3 weeks for a fracture to heal, and that's because children are in a state of growth. and the bones are in a state of growth. That careful balance is pushed towards the growth side in a growing child. So because their bones are already more active in terms of the osteoblasts, the process of repairing the fracture can occur more quickly. In adults, it's more of maybe 8 to 12 weeks to heal a fracture. So much quicker in a child, which is nice because it's not easy to have a young child in a cast. The type of fracture also contributes to how long it takes to heal. A simple closed fracture, a non-displaced fracture, this is going to heal faster than a compound fracture and a displaced fracture. Of course, the presence of infection is going to impact healing. Open fractures, remember compound fractures, have lost the integument, or at least a piece of the integument, and therefore it's much easier for pathogens to get in. And if pathogens happen to get in and infect the bone, it's going to be especially hard to get that fracture to heal. If the person has any concurrent diseases, the time for fracture healing is also extended, especially concurrent diseases that impact the bone. Osteoporosis again. Diabetes is a good example. That's a metabolic disease, and a person who has diabetes, because their metabolism is not functioning optimally, they're not going to be able to maintain homeostasis. They're not going to be able to maintain their hormone levels as well. They're not going to be able to keep absorbing the amounts of calcium and phosphorus that are needed for bone healing, as well as a healthy person. So all of those things can contribute to the time it takes to heal a fracture. We still use casts for fractures, but in modern medicine, we also make a lot of use of other things. We use air boots. If you've ever had a fracture and you've worn one of these air boots, you know that the air boot keeps the fracture site nice and still. It doesn't allow the fracture to move around, which would prevent healing, but it also allows you to weight bear in many cases. And it's that mechanical strength that is going to stimulate bone density. And so it helps in healing. And of course, if you have a bad enough fracture, you're going to either need pins or plates and screws. It all depends upon the type of fracture and where the fracture occurs. So there's lots of options open to the orthopedic surgeon now for handling fracture repair. So let's talk about what's happening at the level of the bone as a fracture heals, as a fracture is repaired. This is a step-by-step process, just like all physiological processes are. When the fracture first occurs in the bone, the first thing that's going to happen is a hematoma is going to form at the bone where the fracture is. As the bone breaks, remember, the blood vessels inside of the bone are going to break as well. And just as we saw with lacerations in the skin, as those vessels bleed, the clotting cascade is going to be activated, and a blood clot will form at the fracture site. And again, this is what we refer to as a fracture hematoma. That hematoma is going to form within minutes of the fracture. After a day or two, the next step in fracture repair involves the formation of a fibrocartilaginous callus. If you think about the calluses that form on your skin, you know that the area of a callus is sort of roughened and hard. The type of callus that first forms in bone is actually a soft fibrocartilage material. Remember, bone and cartilage are both connective tissue, supporting connective tissue. And what will happen when a bone is injured as it's healing, the first new bone will appear as a cartilage material. and that will then be replaced with bone. So this callus that first forms at the fracture site, it's first called a procallus. And again, it's just connective tissue. There will be fibroblasts and chondroblasts in that callus, just like you find in fibrocartilage. The chondroblasts, as we saw before, are going to start secreting the cartilage matrix material. The fibroblasts are going to start producing the collagen fibers, and we're going to end up with this procallus, as it's called. That procallus will then mature into the fibrocartilaginous callus. And from there, once that fibrocartilage callus is in place, the bony callus will form. So just like we saw in the ossification processes in the fetus, when it comes to fracture healing, the cartilage comes first. Fibrocartilage comes first, and then we see a bony callus forming. It takes weeks for the bony callus to form, again, depending upon the age of the person with the fracture. It could be a couple weeks all the way up to, say, 3 or 4 months. There are cells called osteoprogenitor cells. Just think of these as being immature bone cells. Immature bone cells will be the first type of cell to develop right around the edges of the fibrocartilage callus. And they're going to start to divide and mature to produce osteoblasts. And remember, osteoblasts make new bone. Osteoblasts are going to start to create bone. Now they're going to form a type of bone called primary bone. It looks like spongy bone. It has trabeculae. But it's a very young bone, if you will. It's brand new. So we refer to it as primary bone. Those trabeculae that form, that primary bone, is going to infiltrate into the fibrocartilaginous callus and slowly replace it. And then that soft callus, the cartilage callus, will become a hard callus. Now, once that bony callus is in place, the healing process is not finished yet. At this point, the bone it's sturdy. It can weight bear again. The cast can come off, but a process of remodeling is going to occur after that, and for a long time after that, because the callus is going to extend out beyond the normal anatomical lines of the bone. In other words, if you were to take an X-ray at this point, the radiograph is going to show you sort of a bulging out around the fracture line. The bone is not going to look normal where the bony callus is, but the body will remodel that. Those fibroblasts, those fibrocytes, they're going to help remodel this bone and get it back to a more anatomical look over time. But remodeling takes time. On this slide, we're looking at the step-by-step process of fracture healing. So what you're looking at here on the left, this is representing the diaphysis of a long bone. You can see a nice fracture here. This would be an oblique fracture. It's simple. The bone has not penetrated out through the skin, not that we can see the skin. And it's non-displaced. The two fracture ends are aligned with each other. The very first thing that happens when the fracture happens is a hematoma forms. You're going to have hemorrhage in here, and you can see the hemorrhage has actually caused the periosteum to bulge out with blood. The next thing that's going to happen is the fibrocartilaginous callus is going to form. So you're going to get this nice soft Fibrocartilage forming. Remember, it forms first as a procallus, and then it matures into the true fibrocartilage. The next thing that's going to happen is the bony callus is going to form. And you're going to see these trabeculae. You're going to see what looks like spongy bone. It looks just like spongy bone, but we call it primary bone because it's not going to stay looking like this. It's going to continue to progress and get denser and denser until you end up with a healed fracture. And what they're showing us on this slide is that the area around where the fracture was, while it's healed now, doesn't look quite right. You can see there's a little bump right here in the periosteum. There's another bump on this side. It's just thickened around the area where the fracture was. The cortical bone especially is thickened in that fracture area. Now there is a benefit to having this thickened cortical bone, and that benefit is that you are less likely to experience a second fracture at that exact same site while this extra bone is there. It's a little bit stronger right here because of that thickened, protruding area. Now, over time, that's going to be fixed. Over time, the anatomy that should be in this area will be restored in that remodeling process. Fibroblasts and fibrocytes will be involved, sort of helping to get rid of any extra cartilage or connective tissue. Osteoclasts will come in and remove any excess bone, and the normal anatomy will be restored, but it takes time for remodeling to occur. Depending on the age of the person with the fracture, it can take weeks up to years for this remodeling to be finished. Again, the osteoclasts are going to help sort of shave away any extra bone in that area so that it looks more normal anatomically. The primary bone, remember that new bone that forms at the fracture site is going to mature into compact bone in the places where compact bone belongs. Primary bone, remember, is essentially spongy bone. It has these trabeculae, so it needs to be replaced with the osteons of the cortical bone. It needs to mature into cortical bone, again, in the areas where cortical bone is found. Now, even after remodeling has largely been completed, there will be a little bit of thickening in the compact bone around a fracture site, and a good radiologist will be able to see it. The good news, again, is that that's a helpful thing for protecting against a fracture at that same point in the bone in the future. That thickened cortical bone is protective against having that same area fracture again. Now, before we finish up today, I want to say a few things about osteoporosis. Osteoporosis, if you translate it, just means porous bones. And osteoporosis is a disease of aging. Essentially, what is happening during osteoporosis is the person has experienced bone resorption that is occurring at a rate greater than bone formation. The balance between bone formation and bone resorption has been lost. So bone is lost overall, and the density of the bone suffers. In terms of the risks for osteoporosis, females are at a higher risk than males are, although it is possible for men to get osteoporosis. Age is another risk factor. So women who are older than 50 are at highest risk. And that's because these are women who have gone through menopause. And menopause, which is the time when the woman's reproductive cycle has ended, menopause is a time when the woman's estrogen levels have dropped quite a bit. Remember, estrogen is one of the sex hormones, and the sex hormones were in our list of hormones that are necessary for bone growth and for bone strength. So with the loss of estrogen, the bones simply are not maintained as well. You just don't have that balance between bone loss and bone formation. Now, another risk factor for osteoporosis is a poor diet. Of course, a poor diet matters all the way through the life of a human being. In other words, if you are malnourished as a child, if you are malnourished as an adult, the chances of you having osteoporosis in your older years is high. The problem with bone health is that bones need to be maintained. So if you come into your older years, your retirement years, you could say, if you come into those years with poor bone health, then you're at an even higher risk of osteoporosis. A lack of exercise, similarly, will increase the risk of developing osteoporosis because a lack of exercise is bad for the bones to begin with. The other thing to know about risk factors is that there appears to be some risk associated with family history of osteoporosis. So a woman will be asked by her doctor if her mother or her grandmother or anyone else in her family has suffered from osteoporosis. Now, it's important to remember that osteoporosis is not inevitable. If we take care of our bones, especially as females, as women, if we take good care of our bones throughout our lives, we reduce the risk of developing osteoporosis as we age. Now, the bones that are primarily affected by osteoporosis are the wrists, the bones of the wrist, the bones of the back, the vertebrae, and the metaphyseal region of the femur. So if you think about those places, you can imagine where the fractures are going to occur. I'm sure you all are familiar with the fact that older people tend to break their hips more than younger people do. A broken hip is very problematic in an older person. Because they're older, it's harder for the hip to heal. So, broken hip, broken vertebrae in the back, and also the wrists breaking from falls. So it's very common in older people for them to fall anyway. And when they fall and they land on their wrists or they land on their hands with their wrists bent, the wrists are highly susceptible to fracture. So the take-home message about osteoporosis is that it can be prevented. And even for people who develop osteoporosis, there are good treatments available now to help strengthen the bones as we age.